Good afternoon, everybody. My name is Ashraf Raycliffe. I'm the National Occupational Health and Safety Training Manager here at the National Institute for Occupational Health. I hope that my microphone and audio is good. You can just indicate it in the chat box. I see that people are still registering, logging in on. We've had approximately 800 people registering for the session, and I hope that the reminder had gone out to just prompt people to log in on time. I have the pleasure on behalf of the Executive Director of the NIOH, the National Institute for Occupational Health. The National Institute for Occupational Health, NIOH, is a specialized division of the National Health Laboratory Services and a sister division of the National Institute for Communicable Diseases. I'm pleased to welcome you today to another one of our online webinars, and this one is entitled The Pertinent Vaccines in the Workplace. We have certainly learned quite a lot about vaccines in general from a public health point of view, and particularly when it came to the very difficult years of the period of COVID and so on, which is still with us. And we've learned quite a bit on how that impacts on the workplace. Today, we want to, I think, draw on all of that experience, knowledge gained and knowledge generated on the question of pertinent vaccines for the workplace. We have quite a good panel of speakers today, and our first speaker would be Dr. Christelle Nagrusami. She's from the University of KwaZulu-Natal, and she'll be speaking on the relevance of influenza and pneumococcal vaccination in the workplace. Our second speaker is Dr. Zahida Sonde, and you would have seen the slides just pre-webinar of their biosketches. Dr. Sonde would be dealing with hepatitis A and hepatitis B vaccines in the workplace, and she asked the question, do we need one? We look forward to that presentation. Our third speaker is Sister Mary Miller. She is an occupational health nursing practitioner, and she'll be looking at measles, mumps, rubella, MMR vaccine in the workplace. And I think there's another additional topic, if I understand correctly from the WhatsApp, that she was asked to do by her UCT colleagues. And our final speaker is Dr. Uturimeleng Ntamala, and he will be speaking on COVID-19 vaccine in the workplace and why that is still important for us to know about and to be prepared for such emergency response situations. And finally, Dr. Graham Chin, my colleague here at the NIH, an occupational health specialist, will be chairing our Q&A session. With that brief introduction, welcome everybody. I'm now going to ask Dr. Christelle Nagrusami to please share her presentation slides, and then we will proceed with her particular contribution. If you could just change the slides to the non-presenter mode. There we go. Thank you very much. I hand over to you.
Thank you. Good afternoon, everyone. I will be presenting the relevance of influenza and pneumococcal vaccination in the workplace. So an introduction. Seasonal influenza, commonly referred to as the flu, is an acute respiratory tract infection caused by 4 types of influenza viruses, A, B, C, and D. Type A is further classified into subtypes, and I'm sure many of you have heard of these names. And those names are based on combinations of proteins on the surface of the virus, for example, H1N1 or H3N2. Type B is not classified into subtypes, but can be broken down into lineages. Type C is less frequently detected and causes mild infection, so it does not present a public health concern. And type D primarily affects cattle, and it's not known to infect or cause illness in humans. The influenza virus belongs to the family Orthomyxoviridae, and it's characterized by a single-stranded segmented ribonucleic acid or RNA genome. And globally, about 1 billion cases are reported per year. Just remember, not everybody tests for influenza, but of those billion, 3 to 5 million develop severe illness, and then around 290,000 to 650,000 deaths. Coming into our setting, in July 2023, it was noted that worldwide incidence had declined, and in South Africa specifically, the influenza activity was predominantly of type A, which also decreased after a peak in June 2023. These figures are just from the Global Influenza Surveillance and Response System that is managed by the World Health Organization. And if you look here, it's just basically telling us about the subtype that was actually detected, which was mainly influenza type A. And there we can see the peak that they spoke about in June, which then tapered off in July. And that makes sense because June is a winter month, and so it's generally our flu season. Transmission and disease characteristics. So influenza spreads rapidly in crowded areas such as schools, public spaces, and healthcare settings. It's predominantly droplet spread. So if an infected person coughs or sneezes, infectious droplets are dispersed into the air, and then it can infect individuals in proximity. It's also transmitted via fomites. So if a person's hand is contaminated with the virus, they can then spread it onto surfaces, and that can another person can touch that surface and touch the mucous membranes, and so it can be transmitted through that way. The incubation period is generally 1 to 4 days, and the diagnosis is clinical. So we don't often test for influenza, but if testing has to be done, then it's done via a PCR test on a respiratory specimen. Common symptoms are fever, cough, which is usually dry, sore throat, headache, muscle and joint pain, and severe malaise. And treatment is based on the severity of the disease. So mild symptoms occur commonly, it's self-limiting, just requires rest and fluids, and medication can be given for certain symptoms such as fever. Now we're going to speak about vulnerable workers. So we can look at vulnerable workers as, first of all, those workers that are at high risk of infection because of the type of work that they do or the work environment that they're exposed to. So obviously, first of all, healthcare workers or hospital-based, emergency care personnel, workers who are involved in essential services such as teachers, firefighters, police, even cleaners, and any employee working in a crowded, closed space, such as retail workers, hospitality industry workers, and mines. And then we have vulnerable workers who are at high risk of severe influenza disease. And this is what has been documented in the literature. First of all, we note that age, so being more than 50 years old, places you at risk of having severe influenza disease. Pregnant women and women up to 2 weeks postpartum, having a BMI of 40 or higher, medical comorbidities such as chronic cardiac disease, and the list is there. And also ongoing immunosuppressive treatments such as oral steroid therapy. As per also the African treatment guidelines, so vulnerable workers at high risk of severe disease, and this is what our guideline recommends, that those that are more than 65 years old should get vaccinated, pregnant women, those that are HIV positive, and those that have chronic cardiac and respiratory disease. If we talk about the different types of vaccines that are available, and because of time, I won't go through this entire slide, but a single dose is sufficient and immunity lasts for around 12 months. There are inactivated and live vaccines available, a trivalent and quadrivalent formulation, but the most common is the egg one there. That's an inactivated egg-based vaccine, and that one is the one that's most readily available, but it should be avoided in those with egg allergy. And so that's a nice diagram if you want to go back and read about the different types of vaccines and how they are manufactured. I just wanted to also mention avian and zoonotic influenza, because this type of influenza is mentioned very commonly in the media. So influenza A and B viruses circulate and cause seasonal epidemics of disease in humans, but influenza A has been established in many animal species, and animal influenza viruses are named according to the host. So for example, avian influenza will occur in birds. It's distinct from human viruses, but they do not transmit to humans easily, and the public should minimize contact with animals in areas known to be affected by animal influenza viruses, and then obviously perform good hand hygiene and food safety practices. So I just wanted to mention that to differentiate that from seasonal influenza that occurs in humans. Now we'll talk briefly about pneumococcal vaccination and about pneumococcal pneumonia. So Streptococcus pneumoniae is a gram-positive encapsulated diplococcus, and it is a bacteria. So just remember, we spoke about influenza, that's a virus. This is a bacteria. It's a bacteria that colonizes the human nasopharynx, and it's transmitted through respiratory droplets. There's more than 90 serotypes, and it is the leading cause of pneumonia worldwide. But what we know from other pandemics is that pneumococcal pneumonia can occur secondarily to influenza infection. And so during influenza pandemics, pneumococcal pneumonia the incidence of that was noted to be quite high. And then the disease can also occur in other places besides the respiratory tract. So it can also infect secondary sites. For example, the meninges. It can lead to meningitis and bacteremia, and contagious spread from the nasopharynx may cause otitis media. So if we look at the pneumococcal vaccines that are available, there are two different types. Firstly, a 23-valent polysaccharide vaccine, or PPV23, and that has been available since the early 1980s. And then conjugate vaccines have been available since 2009, a 10-valent PCV10, and the other is a 13-valent PCV13. And the PCV13 is what is actually utilized for our vaccination schedule for children in South Africa. But we know that immunity wanes after 5 years of age. If we look at our South African guidelines, what's recommended for pneumococcal vaccination in the management of pneumonia, it recommends that adults who are greater than 65 years old and who are vaccine naive should receive the PCV13 vaccine, followed by the pneumococcal polysaccharide vaccine, the PPV23, a year later. And younger adults with chronic immunocompromising conditions, including HIV, should receive the PCV13, followed 2 months later by the PPV23. And who are vulnerable workers at high risk of pneumococcal infection? So age, first of all, once again, 65 years or older. Healthcare workers are also at risk of pneumococcal infection, and then workers exposed to metal fumes. So this is something that has long been established in the literature, that workers exposed to metal fumes, such as welders, boiler manufacturers, workers in foundries, at high risk of developing pneumococcal infection and invasive pneumococcal disease. And then also workers exposed to mineral dust, specifically silica, are also at higher risk of developing pneumococcal infection. Those that have comorbidities that are listed there, sickle cell disease to nephrotic syndrome, smokers, and those that have alcoholism. So this is a study that was done. I just briefly mentioned it was done in Europe, and it looked at the risk of invasive pneumococcal disease, IPD, and then invasive pneumococcal disease with pneumonia and the various occupations. And it was a case control study with about 4,000 people. And we can see there under the occupational exposures for a welder, there was a definitely significant increase in the odds ratio for invasive pneumococcal disease from 3.79 and then 3.787 invasive pneumococcal disease with pneumonia. That was significant. And if we look at all metal workers, once again, we see that the odds ratios was elevated 2.34 to 2.7. And even for silica dust, though not as high as the other two, but workers exposed to silica dust, there was an increase in the odds ratio there of 1.79. So this is something that is widely known, and it needs to be taken into account for workers that are exposed to metal fumes and also to mineral dust, specifically silica. So some general workplace applications, if we look at occupational health services, obviously with the occupational hygiene, you will be doing a risk assessment, looking for biological agent exposure, and this can be categorized by the workplace being at high risk to the workers, or the individual, where we do an individual risk assessment to see if that worker is vulnerable. And then from that, control measures can be put into place. Very important, a medical surveillance program. And once again, identifying vulnerable workers. Wellness clinics will be doing health promotion about these specific type of vaccines. And part of the occupational health services, offering primary health care for treatment of acute illness like influenza. I won't go into this slide. I'm sure many of you are familiar with this, but basically looking at the risk of infection to the workers from very high to low. So I won't go into this. I'm sure many of you are familiar with that. And then looking at control measures once again in the workplace, such as hand washing stations, putting appropriate policies and guidelines for ill employees, and medical surveillance. Once again, I'm emphasizing that it can review chronic health conditions, looking at the management step, looking at whether it's optimally controlled for workers, and pre-placement and baseline medical examinations can screen these vulnerable workers, or look for vulnerable workers and identify them quite early on. So respiratory pathogens cause significant morbidity and mortality among those that are vulnerable to severe or complicated diseases, and early identification of vulnerable workers is crucial to promote and maintain employee health and wellness. Influenza increases the risk of pneumococcal disease, and therefore both vaccines should be encouraged in vulnerable workers at risk of severe outcomes. And I think that would be my take-home message, that third point. High-risk occupations such as healthcare workers and workers exposed to metal fumes, as I've mentioned, must have appropriate education and training, and medical surveillance programs can screen and identify at-risk vulnerable individuals. And that was my last slide. Thank you.
Thank you very much. That was Dr. Crystal Nagunsami, and the relevance of influenza and pneumococcal vaccination in the workplace. Please, if you got specific questions to this presentation, if you could just type that in the question and answer box, the Zoom question and answer box. Dr. Nagunsami and the other colleagues will be looking at your questions in the question and answer box. I think there is one from Genevieve Bota, and we will continue to monitor that question and answer box to ensure that we answer your questions there before all of them before we close. Our next speaker is Dr. Zahida Sonde. She's from the Occupational Medicine Division at the School of Public Health at the University of Cape Town, and will be talking to hepatitis A and hepatitis B vaccines in the workplace, and answering the question, do I need one? So if you could just, there we go. Thank you very much, Dr. Sonde. I hand over to you immediately.
Thank you very much for the introduction, and thanks very much for the opportunity to present today. So I'll be discussing hepatitis vaccines relevant in the workplace, specifically hepatitis B and hepatitis A. It doesn't seem like my slides are progressing. Okay, there we go. So, sorry. So the type of viral hepatitis, then, just as an overview that we have, is A, B, C, D, and E. And the most common of these are hepatitis A, B, and C. As you can see, hepatitis A and E, it's predominantly spread via the fecal-oral route, so by contaminated water and food. And then B, C, and D are transmitted by contaminated blood and body fluids. So just to mention then that you can only get hepatitis D if you have already got hepatitis B, or you are co-infected with hepatitis B. And then vaccines available in South Africa for hepatitis are only for hepatitis A and hepatitis B. There is no vaccine available for hepatitis C. And if you're vaccinated for hepatitis B, that will protect you against hepatitis D. Before we can understand why we need to prevent hepatitis B and vaccinate, it's important to understand what are the possible clinical outcomes of infection. So we can have acute infection, which can be symptomatic or asymptomatic, and this and you can recover, or you can have severe fulminant infection with liver failure, or you can progress to chronic infection, so that's chronic hepatitis, or you can have a chronic carrier status. And then of those who have chronic hepatitis B, there's about a 15 to 40% chance of developing other complications like liver cirrhosis and failure, as well as liver cancer. So the context is important to understand in South Africa because it affects our transmission risk. And in South Africa, hepatitis B infection is endemic. It's estimated that there is a 6.7% seroprevalence, And if you look at the figure over there, that would put us in the high to intermediate endemicity category. However, that figure is most likely underestimated because we don't have very good disease surveillance. And also notably, we've got a high prevalence of HIV infection in South Africa. And many of those who have hepatitis B are co-infected with HIV. For the transmission risk, I've mentioned that hepatitis B is transmitted by infected blood and body fluids and sexual fluids. It is also present in saliva, although it's not readily transmitted this way. So it's not readily transmitted by kissing or sharing eating utensils. There is, however, a risk with sharing toothbrushes or if there is a human bite and there's a break in the skin. And then the virus in the saliva could enter the bloodstream. So we worry a lot about HIV transmission. And if you look at the first table over there, the risk of transmission of hepatitis B is much higher. So for a hollow bore needle stick injury, the risk of transmission can be up to 60%. And then what's also important about hepatitis B transmission is that the virus can remain viable for up to 7 days on surfaces. So theoretically, that then means there's a higher risk because it sticks around longer than what HIV and hepatitis C does. So which workers are at risk? Well, the obvious one is our clinical healthcare workers, but our non-clinical health workers are also at risk. So that could be our cleaners or any other staff like admin staff and engineering staff who work in clinical areas and can come into contact with contaminated surfaces in those clinical areas. Our lab workers who work with clinical specimens are at risk. Our police, firefighters, armed forces, and security are also at risk because they either could provide emergency care or they are at risk of being victims of violence. Workers in facilities for the disabled or correctional services are also at risk of violence or human bites. Accommodation staff, waste or recycling staff, and parks and garden employees can come into accidental contact with soiled linen or other items like contaminated broken pieces of glass. And sex workers is an obvious one. So among those workers, it's also important to remember that our HIV-infected workers are a vulnerable group. So in terms of our vaccinations, hepatitis B is a vaccine preventable disease. The hepatitis B vaccines are safe. They do not contain live hepatitis B, so there's no risk of transmission of hepatitis B. The dosing schedules for hepatitis B can vary depending on the type of vaccine, whether it's a child or adult being administered to. If there's a need for rapid immunization, for instance, if someone is traveling and they need an accelerated course of immunization, or if there's been a previous non-response to hepatitis B vaccination. Response rates do decline as one gets older. So over the age of 40 years already, response rates can decline. And then host factors such as having liver cirrhosis or being immune suppressed can actually result in a lowered vaccine response. Immunity with the vaccine is up to, is at least 20 years, but most probably lifelong. And I think importantly there is that we no longer recommend 5-yearly boosters for everyone, but for certain groups of immunocompromised individuals, this may still be advisable. So what vaccines are available? In the public sector, children who are born from 1995 do get it as part of the expanded program of immunization. Health workers amongst adults do get it as pre-exposure prophylaxis or prevention. And then post-exposure prophylaxis is available for adults who are victims of sexual assault. In private, we have 3 different types of hepatitis B vaccines currently available, and they cost up to 150 Rand per dose. The primary vaccine series consists of 3 doses at 0, 1, and 6 months, and alternative schedules are available. it is recommended that one checks the antibody response or the immune response about 1 to 2 months after receiving the vaccination, because up to 10% of people will not mount an immune response and require revaccination. And for those who remain susceptible, there is hepatitis B immunoglobulin available in case of accidental exposure. However, this is not as effective as the vaccine, and it's considerably more expensive, around 1,000 to 1,300 Rand per dose, and you need 2 doses. So then moving on to hepatitis A, it is also endemic in Southern Africa. It's the commonest cause of acute viral hepatitis in South Africa. It's a notifiable disease. An infection is usually self-limiting, but severe infection with fulminant hepatitis and liver failure can occur. And as I've already mentioned, it's predominantly spread via the fecal-oral route. Workers at risk are health workers, outdoor sewage workers, those working with children, employees of institutions such as frail care and rehabilitation centers, those who travel internationally for work to endemic areas. And then also our food handlers may not be at a higher risk of infection, but they do pose a higher risk for transmission of the virus. With regards to hepatitis A vaccination, it's not freely available in the public sector. There are 2 vaccines available in the private sector, and it costs up to 350 Rand per dose. So the dosing schedule usually includes a first dose and a booster at 6 months. And with those 2 doses, it's 95% efficacious and provides lifelong immunity. For immunocompromised individuals, they need another booster. And although we do have hepatitis A immunoglobulin for post-exposure prophylaxis, we can also use the vaccine for post-exposure prophylaxis. I think what's interesting to mention here is that many adults in South Africa actually do have natural immunity to hepatitis A. So they would have acquired natural infection and had self-limiting infection, developed immunity. So data from the NHLS between 2005 and 2015 shows that up to 88% of adults actually had natural immunity for hepatitis A, and that has implications on vaccination. So it might not actually be cost effective to test everyone for immunity, but those who are at risk, you should just, who are at high risk, workers at high risk, one should probably just vaccinate. Combined vaccines, there is a combined vaccine available for hepatitis A and B. It's called Twinrix. It's about 370 Rand per dose, and the standard series is 3 doses. And then in closing, my take-home points are that both viruses, Hep A and B, are endemic in South Africa, which increases our risk of exposure. They are vaccine preventable. Their consequences can be debilitating or fatal. And primary prevention through vaccination is recommended for high-risk workers. Thank you very much.
Thank you very much. Yes, that was Dr. Zahida Sonde from the Occupational Medicine Division at UCT on hepatitis A and hepatitis B vaccines in the workplace. Our next speaker, I'm pleased to welcome, and I'm very grateful for her. It is the early hours of the day for her in Seattle, Washington State, I think it's called. And I'm now welcoming Sister Mary Miller, an occupational health nursing practitioner, who's an honorary lecturer at the same division at UCT, and she'll be speaking to us. Have I got the title correct, Mary? Is it measles, mumps, rubella vaccine, or is that's changed? Is that the same?
Well, I was asked to include some comments on varicella chickenpox.
Excellent. Please, I hand over to you. Please proceed.
So thank you very much for having me at this early hour. Still very dark here. I don't know quite. I'm indicating share, but I don't see. Is it visible on your side?
Not yet, Mary. Should I try from my side?
Yeah, I see the share arrow, but then,
If you click on it, and then you would get the screen with whatever's open currently on your desktop.
upload it. Well,
Yeah.
it's not. Sorry, I don't know why.
Oh, I think you might be sharing your full screen. Yeah. If okay, so let me do it from my side. If you could unshare on your side.
Okay. Actually don't know how to unshare. I'm sorry. Can you just open it at your
Okay.
side
Yeah. Okay, let me do that.
and then share your screen so I can advance perhaps?
You may just have to tell me next, and then I can do that for you. So let me just double check if. Do you see the full slide or part of it?
Yeah, I see the whole slide now.
Okay, one moment.
I'm sorry. So if you share, I should be able to move it
No, I'll have to move it, I think, on my side.
here. Okay.
Okay, one moment. I just need to go to the oh, this is okay. There we hold on. Am I clicking on the right one?
You can see it, right, Ashraf?
Yes, I just need to change the setting here, and I'm struggling to find that. One moment.
Hi, Ashraf. I think it's fine. It's full from our side.
Oh, is it full from your side?
Yes,
Okay.
sir.
Then you can proceed, Mary. I'll just move the slide for you. Just say next.
Okay, all right, thank you. I'm sorry about that. So hopefully this is going to be a review for most everyone here. So I originally was asked to speak about measles, mumps, rubella, and then added varicella here as well. They sort of all fall together. My focus is on health workers, but there are others who are at risk, which I'll include at the end. So next slide, please. So we've already had some very good groundwork from the previous presenters. So just to remind us why these are so important is that they prevent and reduce the spread of infectious and communicable diseases. And they're the most cost-effective and efficient way to reduce these illnesses worldwide. And healthcare personnel in particular are at risk for exposure, infection, and transmission of these diseases to their patients, the community, and essentially it can affect everyone. This is where the intersection of public health and workplace health and safety intersect, I believe. And these vaccine preventable diseases are also more severe in adults. And most people who are vaccinated with MMR and varicella vaccines will be protected for life. Next slide, please. So the vaccines boost the immune system in order to respond to and prevent the disease, despite potential and possible exposures. It's estimated that 4 to 5 million lives are saved each year worldwide through the use of vaccines. And in particular, because we now have at least 20 vaccines to prevent life-threatening diseases. Vaccines are a component of primary health care, and it's part of the human right toward health and part of the global effort to prevent, detect, and respond to outbreaks. Currently, 1 in 5 children have no access to vaccines. And the goal by 2030, according to the US Centers for Disease Control and Prevention, is to save 50 million lives. Next slide. So these illnesses, all 4 of them are very contagious. They're spread through respiratory droplet. Pretty much similar symptoms for many of them. Measles include fever, cough, runny nose, watery red eyes, often a rash covering the whole body. These are particularly serious in children as well, but also can lead to seizures, pneumonia, brain damage, or even death, and of course, increased risk for pregnant women. Mumps, similar fever, headache, muscle aches, tiredness, loss of appetite, swollen and tender salivary glands, can lead to deafness, brain swelling, and particularly in adult males may affect fertility. Next slide. Again, rubella, fever, sore throat, rash, headache, eye irritation can cause arthritis in up to half of the teenage and adult women. And then especially concerning is exposure during pregnancy with miscarriage and possible birth defects. Chickenpox or varicella causes itchy rash, fever, tiredness, loss of appetite, and headache, and can lead to skin infections, pneumonia, inflammation of blood vessels, also swelling of the brain and spinal cord. Later in life, for those who do not for those who have infection without vaccine, shingles or herpes zoster can occur, which is an incredibly painful burning blisters, often along a nerve pathway. And there's now vaccine for those, typically recommended over the age of 60. Next slide. So these data, I could not find, these are from the Children's Hospital of Philadelphia from 2020. I couldn't find more up-to-date data. These are probably an underestimate. Given the COVID pandemic, there were many, many children who, in particular, that were not getting vaccines or other healthcare for that matter during the pandemic. So these are likely a pretty significant, well, I couldn't say if it's significant, but these are probably an underestimate given the lag we've had in basic healthcare over the last several years in many places. Next slide. So there are some side effects from these vaccines, typically a sore arm from the injection or redness, sometimes fever and a mild rash, sometimes some swollen glands, achy joints, and sometimes, you know, due to fever, seizures may occur, but this is extremely rare. And those who should not receive a vaccine are if someone's pregnant or suspected to be pregnant, have serious immune system problems, or have active untreated TB. Some would say that if you have a reaction to vaccines, your immune system, it indicates your immune system may be working well. I don't have a data for that at the moment, but that's recent information I saw. Next slide. So recommendations for vaccines come from a variety of organizations and agencies. The U.S. Centers for Disease Control and Prevention, CDC, recommends that the vaccines for measles, mumps, rubella, and varicella should be given to all healthcare personnel, which includes anyone dealing with patients. The WHO from 2021 recommended measles vaccine for all healthcare personnel, rubella and mumps if it's included in the national immunization program. But as most of you would know, that most of these vaccines include all three MMR, so it's more efficient and cost effective to give all three. And then the WHO mentions varicella for susceptible healthcare workers and primarily those involved in direct patient care. Then often there are national health ministries and departments that have their own recommendations, and many countries have their own advisory committees on immunization practices. So some of these recommendations could vary according to your location. Next slide. So the recommendation for these vaccines include to provide, if a worker does not have serologic evidence of immunity or documentation of prior vaccine or infection, that 2-dose vaccines for MMR and varicella be given typically around 4 weeks apart. these are live vaccines, which is the reason why they typically confer lifelong immunity. And the cost of the vaccines with or without serology testing, it can still be less expensive, certainly less expensive than illness among workers or their patients, which includes medical cost and lost work time. Due to the incubation period for these illnesses, lost work time could range anywhere from 7 to 25 days. Which is a significant impact on the workplace. Next slide, please. No, the one, so this was just, this was from a project I did when I was at Red Cross Children's Hospital in Cape Town, and identified these countries that do provide immunization for healthcare personnel at no cost to the workers. So it's not an exhaustive list by any means, but this gives you a sample of how this is handled worldwide. Next slide, please. So I wanted to bring your attention to the Occupational Health and Safety Act this is of South Africa from 1993, particularly sections 8 and 12 that talk about the general duties of employers to their employees in terms of providing a safe and healthy work environment, and that employees have a duty to identify the arrangements that identify the work throughout their facility to identify who's liable and exposed to the hazards from their work. And the next slide, please. So that they identify the hazards and identify the risks, prevent the exposures, prevent the exposures of the employees and the hazards that have been identified, and then carry out an occupational hygiene program that may include biological monitoring and medical surveillance. Next slide. In the Western Cape province where I was working at the time, this was another policy from 2016 adopted by the Safety, Health, Environment, Risk, and Quality Committee to provide a healthy and safe environment improved and maintained through the identification and mitigation of associated risks in the workplace, and to ensure measures aimed at preventing occupational injuries and diseases are implemented. Next slide. So, no, the one before that, sorry. So all healthcare personnel with responsibilities involve patient care or contact with patient care wards should be included in an immunization program, and that preferably at no cost to the worker. This would help include improve compliance. And of course, I should expand the occupational groups at risk. Anyone working with children, like teachers, daycare workers, healthcare personnel would mean those in hospitals, clinics, nursing homes, emergency care personnel, home care, students. So anyone that has potential to be exposed. Those without documentation of illness or vaccine for measles, mumps, rubella, or varicella should receive vaccinations with or without serology. It would be cheaper if it's more cost effective depending on the history of the childhood vaccination program in the respective communities, how likely it is that adult workers have already received these vaccines. The program should be initiated with new hires, and then of course documentation, record keeping should be maintained by the occupational health clinic personnel. So, and then I have a list of resources and can provide those to anyone interested. So thank you very much. Sorry, my timer went off just a couple minutes ago.
Thank you very much, Mary. That was well timed. I'm going to just unshare your slides, and I'm going to ask our next speaker, and that was Mary Miller, the current speaker, occupational health nursing practitioner dealing with measles, mumps, rubella vaccine in the workplace. Our next speaker is Dr. Itumeleng Ntatamala, and he is from the University of Cape Town Occupational Medicine Division as well. I'm glad that you have joined us live and directly, Itumeleng. And will you be sharing your slides? I think you might be muted. Oh, great. Go ahead.
Let me share from my side. Doesn't seem to allow me to.
Okay. Should I just share from my side?
I think so, Ashraf. It seems like I've been blocked. I'm not sure why.
Let me just double check the settings here. That should not be the case.
Hi, Ashraf. Dr. Itumeleng is part of the co-host, so he should be able to share.
Able to share, yeah. If it doesn't work, I'll just share from my side.
Okay. Let me try one more time. If it doesn't allow, then okay, doesn't seem to allow. Sorry about that. I think it's best if you do.
Okay, let me do that. And there we go. Okay, is that visible?
It's visible. If you could just do presenter mode.
Okay, one moment. There we go. And it's not presenter mode at the moment.
Not yet.
There you go. Can you see the full screen?
Yes, thank you so much.
Yeah,
Right,
please proceed. Thank you.
And good afternoon to everyone. I see we're left with just 15 minutes before the end of the session, and I'll try to compress these slides. I'll be speaking on COVID-19 vaccines and the workplace. If we could go to the next slide. I think it goes without saying that we've come from quite a hectic pandemic, and most of you will remember, hopefully, that COVID-19 is caused by the SARS-CoV-2 virus, and of course is associated with a large range of symptoms, and these are would begin from mild right up to severe illness and sadly death in some cases. I've listed there some of the common symptoms, including dry cough, fever, chills, tiredness, and headache. And less common symptoms, but which we are seeing in clinical practice: loss of taste, dyspnea, etc. Of course, these symptoms may appear within 2 to 14 days after exposure to the virus. But what we've seen, and I see it in the Q&A as well, is that there are long-term symptoms as well and other medical complications that have presented, and of course, commonly known as long COVID. Next slide. And you can click as well. So in this slide, I just wanted to indicate the some of the good studies that have been done, which have identified more than 50 long-term effects of COVID-19. And of course, they defined long COVID as ranging from symptoms ranging from 14 to 110 days post-viral infection. And do note that quite a large number of patients present with symptoms, around 80%. The most common being fatigue, headache, attention disorder or brain fog, as commonly described, and hair loss, and dyspnea as well, shortness of breath. Next slide. What we've seen, however, is that COVID-19 vaccines have been essential in preventing COVID-19, SARS-CoV-2 infections, severe disease, and deaths during the pandemic. Looking, or at least in hindsight, what we've been seeing are very good studies this year showing the efficacy of these vaccinations, combining quite a number of studies to do what is called systematic reviews and meta-analyses as well. So what the figures are coming out, figures that are coming out indicate that the full COVID-19 vaccinations have got high efficacy, around 44.4% 0.5% for preventing asymptomatic infections, around 77% for preventing symptomatic infections, 95% for preventing hospitalizations, around 90% for preventing severe disease, and 85% for preventing deaths as well. Next slide. Other studies that have focused on specific populations, one of this looked at vaccinations, the efficacy of vaccinations in elderly populations greater than 60 years of age, also noted that these vaccines were highly effective in preventing SARS-CoV-2 infections and also reducing the number of COVID-19 related deaths. Next slide. So it goes without saying that over time, we've seen the effectiveness of these vaccines and the benefits of these in the general population and certainly in working populations as well. I thought it would be important for us, however, to look at the situation that we currently have in terms of the number of COVID-19 vaccines that have been administered in the country. Very interesting, if you look at the graph, during the height of the pandemic, quite a number of vaccines had been administered. But if you look at the arrow at the end, very recently, we've only got around 8,000 vaccines that have been administered. And this, of course, is quite concerning. If you move to the next slide. These are some of the statistics that have been reported by the department, the National Department of Health. And you can see it notes there that around 49%, around 50% of eligible populations in the country have received at least one dose of COVID-19 vaccines. If you click again, even more concerning, however, is that the total general boosters that have been advocated for and made available, very few of these have been taken up as well. So around 4 million have been taken up, but even less so for immunocompromised populations, and even less so for the total continuous booster doses that have been advocated nationally. Can move on to the next slide. So COVID-19 and workers in the country. This is a very interesting study that was authored by Professor Chibai and colleagues, and it looks at the COVID-19 response in relation to workers in the country. And as you can see in the pie chart that there are a number of professions that had been, or job categories where COVID-19 had been diagnosed, and these are figures that have been supplied by the National Institute of Occupational Health. What has been made very clear in the study as well is that we have seen generally high uptakes of COVID-19 vaccine in health workers, in the mining industry as well, which are generally having good occupational health services, and where concerted efforts were made to ensure that workers have access to these vaccines as well. We've got very little data on other industries as well. However, it is argued that it is likely to be very close to the general population figures of around 50% vaccination rates. Next slide. So this is a matrix that is included in the study, and I thought that's just important in order for us to remember that there are differences in the risk of COVID-19 infections, depending on what industry one is in. As you could see, industries that are public sector facing, so public service, protective services, healthcare sector, or social care, education and transport are industries with these working populations that are at increased risk of COVID-19 infections as well. Other factors, of course, individual factors and individual vulnerabilities must be taken into account, and work-related factors such as the ability to social distance, and of course, the ability to be able to have medical surveillance, access to vaccinations, etc., should also be considered as well in light of these, as one looks at these industries. Next slide. I thought it would be important for us to compare what is happening in South Africa and across the world. And if you could click twice, Ashraf, what is quite interesting here, the estimates from the US looking at COVID-19 vaccine uptake in major occupational health groups is also interesting. As you can see at the bottom, industries such as those in healthcare, healthcare practitioners, in the life physical sciences or social sciences, in education and training, and have generally very high vaccine uptake of over 80%. However, concerning industries, including construction, maintenance, farming, fishing, transportation as well, have in that context had very low vaccine uptakes as well. So quite interesting for us to also consider whether or not we are covering our different industries correctly or at least appropriately, and which other ones can we be focusing on to ensure that vaccines are available and that uptake is encouraged as well. Next slide. So in terms of the current recommendations, this is a circular instruction, a circular from the Western Cape Department of Health. And I thought this was quite an interesting one because it is the most recent that I could find, released on the 13th of October. And it indicates that the national response and the national recommendations, indicating that the National Department of Health has announced that individuals eligible for COVID-19 vaccine booster doses can now receive boosters every 6 months following their previous boosters, right? And this is particularly important for us to note in the call for those who are increased risk of severe COVID-19. So workers who have comorbidities such as diabetes, hypertension, heart disease, and other immunocompromising conditions. So this is quite important for us to note. And if we move to the next slide. I just put it here for you to be able to note again the circular that came from the National Department of Health, and interesting again, also reiterating that as of early this year, persons greater than 18 years and older will be eligible to receive additional booster dosages. And of course, there's specific durations that need to be met for those dosages. But it's clear there that if you are for adults older than 50 years and above, so they'll be eligible to receive a total of 5 doses, and adults 18 to 49 eligible to receive a total of 4 dosages as well. Next slide. So this is again a reminder to all to have to be cognizant of the code of practice that has been released by the Department of Employment and Labor, which also speaks to COVID-19 vaccinations. But remembering that COVID-19 vaccinations are just one bit of administrative measures, it is still important to ensure that we continue with our workplace risk assessment plans, and as indicated in this code of practice. So we can quickly move to the next slide. And click again. So I just put in here for your convenience some of the pointers that have been raised around the COVID-19 vaccines and how the code of practice itself reiterates again, ensuring that risk assessment plans are conducted and implemented in respect of this code of practice. Okay, we can move on. Okay. So there's other aspects that the code speaks to as well. You can click twice, Ashraf. Okay. Indicating the issues that have to be taken into cognizance. It's not just about providing the access to the COVID-19 vaccine, but about information and training, but counseling as well, and ensuring that counseling happens for workers that would not prefer to have COVID-19 vaccines. So you can move on to the next slide. Next one. So in conclusion, with 2 minutes left, and the take-home message from my presentation is that the impact of COVID-19 on workplaces has been significant, and the risk still remains as we continue to see that COVID-19 lingers on in the background. It is important for us to continue to be vigilant and to ensure that the preventive measures within the workplace continue to be put in place, and that COVID-19 vaccinations have been shown time and time again to be effective in reducing SARS-CoV-2 infections, their severity of disease, and deaths. And I think this is a key message that should continue to be reverberated within workplaces. So workers should be informed of these options and encouraged to obtain boosters or updated COVID-19 vaccines as other jurisdictions, such as the US, call them. And they use the word updated COVID-19 vaccines to move away from the from the concept that the COVID-19 vaccines are not improved upon, because they continue to be updated, similar to how influenza vaccines are, and that they will likely be a move over the coming years for COVID-19 vaccines to be treated very similarly to influenza vaccines. It is important for us to also remember to address issues of access, particularly to workers in industries that are quite vulnerable or underserved, as I've indicated, and those that lack occupational health services, and those that may be affected by issues of vaccine hesitancy. Thanks, Ashraf.
Thank you very much. And that was Dr. Itumeleng Ntamala. I'm glad he's with us. He almost had to address a personal urgent request, but I'm glad that that has been delayed slightly. Thanks for being present with us today. With the permission of all the attendees, we are going to go slightly over our 3 o'clock closing time. And I've discussed and said that we could close exactly by 10 past. I'm now going to hand over immediately to my colleague, Dr. Graham Chin, an occupational medicine practitioner here at the NIOH, serving all of the employees of the National Health Laboratory Services, and he will be managing for us the Q&A session. Over to you, Graham.
Thanks, Ashraf. So we are time sensitive, and maybe when it comes to vaccines, we've always noticed, because the National Institute for Occupational Health often receives questions on our hotline through the public forum around vaccines, and there's high-level themes that often come up, and I'm even seeing it in the Q&A box. So if I can maybe ask the panelists who have just chatted with us and given such excellent presentations, when doing a risk assessment in the workplace, at what point do you decide that you need to now implement a vaccine program? And maybe I can ask Dr. Nogosamy what her thoughts are, maybe just some practical tips. We can't go into big details here, but maybe just some experiences of how does one actually go about deciding I need to put in a vaccine program now in my workplace based on the risk assessment. Dr. Nogosamy, are you with us?
Yes, Graham, I'm here. Thank you. Yeah, I think we did sort of have a prelude to that in some of the Q&A questions, but obviously it would be part of the occupational health service involving the entire team. So right from the concept of the risk assessment and the hygiene assessments, and then obviously implementation with the occupational health practitioner, the occupational medicine practitioner, forming part of the surveillance program, and what sort of control measures to put into place. So I think it's something that really, it's not a quick thing. It's something that would need to start from the risk assessment and then going forward based on the workplace assessment. And once again, in individualized assessment, because not every worker is the same. And that's what people need to remember, is that when we are assessing these employees, you must be individualized in the assessment of the chronic medical conditions that they have, of what they're exposed to in the workplace, and then what is their risk for severe disease.
Okay, thank you. Maybe if I can bring Dr. Sonday in, if your risk assessment indicates now that sort of vaccines are required for a group of workers, how does one deal with maybe vaccine hesitancy or workers that perhaps feel a bit apprehensive of receiving a vaccine? Have you got any tips to share around that? How would one approach perhaps implementing a vaccine where there might be slight resistance of a vaccine program?
Thanks very much for the question, Dr. Chin. So I think that it's important if a vaccine is recommended in the workplace to firstly have information, education and training of your staff so that they understand the risk in the workplace, why they need it, and how the vaccine will mitigate that risk. If there are workers who do have vaccine hesitancy, I think there's nice guidance in the Code of Practice on the management of SARS-CoV-2 in the workplace, and we can follow that in general, where you counsel the worker on the risk, and you counsel them on the benefits of vaccination, you counsel them on the safety of the vaccination. You also allow them an opportunity to consult, so they can consult with their labor representatives, they can consult with their medical practitioners, they can consult with their colleagues. And I think if it does come to a point where, despite all of your efforts, and there's no medical contraindication, then it may be that the employee needs reasonable accommodation in the workplace. Thank you very much.
Sister Miller, I know you've been in this game for a long time. I don't know if you've got anything to add. I mean, I'm sure you've dealt with people who are a little bit reluctant to vaccinate. How would you, in your experience, have you got anything to add?
Right, reluctant, it's quite the large continuum. Reluctant to actually vaccine deniers, which we, of course, in the US and elsewhere have had to deal with on every type of vaccine. I think I concur with what the previous respondents said. There's just a lot of education that needs to happen. And I think also providing the opportunity, and because it's a workplace, these are workplace issues that they have to be provided by the employer. Ultimately these programs should, at least for the vaccines I mentioned, among many others, begin in childhood. And I know in some countries, some have mandatory vaccines, some provided to the public sector does not have access to some of these vaccines. So I think making it more consistent and uniform in terms of who's eligible, who has access, how it's provided, and education. Ultimately, these diseases can impact a community's economy if the and I think that's not emphasized enough in terms of the impact of low uptake of vaccines. And so I don't have any magic suggestions, but I know a lot, making them available, accessible, and adequate education is really the key to improving compliance and uptake.
Yeah, okay, thanks. And maybe just one last theme that often comes up, if I can bring Dr. Ntatamala in. Who can actually access vaccine records in the workplace? We both look internally in the company, managers, HR, is that acceptable? And maybe even externally, auditors and inspectors. Your thoughts, Dr. Ntatamala, who can access vaccine records, and who should the clinic be showing vaccine records to?
Yeah, thanks, Dr. Chin. So at a very basic level, the employees themselves should have access to their own records as well. And of course, the occupational health providers or the occupational health team, and they're generally bound by the Health Professions Council on issues of confidentiality, and the South African Nursing Council on issues of confidentiality. Because I think with any records, be it vaccine records or medical surveillance records, that is quite an important aspect of it. It does come up quite a bit in terms of the inspectors that come on site, particularly from the Department of Labor, requesting to have access to these. And the South African Association of Occupational Medicine, so SASOM, has got some guidelines around these. So the general approach is that if the inspector is an occupational health care provider themselves, and we do have those who are trained, they could have access to these, because they are, of course, bound by the Health Professions Council Act, etc. And where they are not healthcare providers, through the POPIA Act, etc., they would have to go through that mechanism to get permission to access these results as well. It's also important to highlight that there are different kinds of information that one can provide. So what I've presented, for example, is group data. So you can give a sense of how many workers within this factory have had COVID-19 vaccinations, which are anonymous and do not indicate any workers per se. And you can indicate which months these vaccines have been provided, which is quite different from very personalized named data, where lots of legalities and issues of confidentiality come into place as well. But there are quite nice guidelines that have been written. I think these could be shared as well. Yeah.
Yeah, I guess it's all about the intention, hey, of what the result's going to be used for. Ashraf, you know what? I'm looking at time, and I think we've touched on the big theme questions. I'm going to hand over back to you, and really thank you to my colleagues. But over to you, Ashraf.
Thank you very much. Yes, and on that note of thanks, let me go straight over just to thank everybody that had both in the background and in the weeks and months before this particular webinar contributed to making this a success. And let me start with the speakers. That is Dr. Chriselle Nagursamy. And I'm just going to, okay, that might be my apologies. That might be my alarm saying the 10 minutes is up, I think. So apologies for that. I hope you didn't hear that. So that's, yes, Dr. Chriselle Nagursamy. Thank you very much for your contributions from UKZN. Dr. Zahida Sonday, Sister Mary Miller, and Dr. Itumeleng and Tatamala. Thank you very much for your contributions to today's program. And as I've noticed in the chat box, people have regarded your contributions collectively as very important and valuable and educational. So thanks for that. And then obviously to you, Graham, Dr. Graham Chin, for just hosting our Q&A slot there at the end. And then just to mention those who you would not have seen perhaps on the screen or presenting in their names, that's Professor Mzumkulu Zungu, and that's been leading our team here with regard to this joint project with NEDLAC. Dr. Sujata Hariparsad, she's also from the UKZN, and together with her and Dr. Itumeleng Tatamala, they coordinated, the two of them, the organization of the program, etc. And then finally, in the background, Professor Rajan Naidu from UKZN and Dr. Professor Muhammad Jibe from UKZN, from UCT. Oh, I almost got that wrong. And then finally, our colleagues internally, particularly Dabani Zwani and his team in the IT section for making sure everything works. With that, thank you to all the attendees for allowing us to go slightly over time, approximately 10 minutes. And again, as we've answered in the chat box, yes, we will circulate the links for all of the presentations and video recording of this event and other administration after the webinar. With that, I say thank you, everybody, for joining this particular webinar of the NIOH in a partnership with NEDLAC and supported by the Compensation Fund under the Department of Employment and Labour. Good day, and see you on our next webinar.